Top Bed Talk.
This piece is presented in two parts. This is part one.
Well, hello and welcome to our ERAS Chicago 2020 live virtual meeting. Thank you so much for joining us in our little breakout room, ERAS 2020. I'm Desiree Chappell, co-chair for our breakout session, and I'm joined by Vicki Morton, who is also co-chairing. Vicki, I want you to tell us a little bit about yourself.
I live in Charlotte, North Carolina. I'm a nurse practitioner and also the director of clinical and quality outcomes for an anesthesia group that hired me essentially to come and oversee, expand, sustain an ERAS program that had just started in colorectal. They had one service line, one hospital, with the goal of expanding to all of the hospitals within our market and expanding the service lines. So we now have within that one hospital, 7 total hospitals, but we also have 2 outside hospitals that we provide anesthesia for. So total of 9. I think now 19 service lines since January of 2017. So a lot of work has been done with the entire group, the ERAS group. It takes a village for sure. And so that's my main role. Take care of some other quality initiatives within our anesthesia group in the hospital, but my main role is the ERAS program.
So we have Gina McConnell. She is a nurse from North Carolina as well.
Thank you, Desiree. Of course, I love ERAS. I love talking about ERAS. I am a nurse out of Raleigh, North Carolina. I work at WakeMed, and I was fortunate enough to be on the team that implemented cardiac ERAS back in 2017. As that went full steam ahead, we realized the need for a designated ERAS coordinator, which I became in January of this year. And now we are working on 6 pathways. Our hospital kind of started backwards. We didn't have any. We started with cardiac, and now we have 6 that we're working on. So I am very busy, but loving it.
You started with the hardest one.
I know, right?
Gina, I always tell people whenever I talk about you, you kind of brought the cardiac ERAS program to your partners and your colleagues there at WakeMed. So this was an initiative that kind of came from you that you heard at another meeting, correct?
That's right. Didn't really know the components of ERAS. And then when I heard the success and outcomes from other service lines, it was like, wait, why are we not doing this in cardiac? So took it back, and you're right. I had a really great team that welcomed me with open arms and embraced me. A few barriers, of course, and then we went from there.
And I think you had a paper published with Jetson with Dr. Williams too, didn't you?
You're sweet. Yes, with the AATS, our first year outcomes. First one was in nursing, 2018. Second one was our 1-year outcome. So yes, you're right.
So our next guest, we have Cheryl Crisafi, who is also a nurse. Cheryl, thank you so much for joining us. Tell us a little bit about yourself.
I am very passionate about ERAS. I was hired as a bundle coordinator in 2014 at Baystate Medical Center in Springfield, Massachusetts. And what a bundle coordinator is it's a payment plan that we entered into with Medicare. And we got one lump sum for up to 30 days after patients left a hospital. And they needed to make sure that we were implementing all the evidence-based practice, best protocols that we could to ensure that this was going to be not a revolving door of people coming back. So we got started on the evidence-based practice model with our bundle. And after several years, we kind of felt like, where do we go from here? We'd reduced our length of stay. Maybe not, our length of stay is our challenge, but we had reduced our readmissions significantly, and we had significantly impacted our patients going home versus rehabs. So our quality was starting to show definite improvement, and we knew we needed something else. And that's where ERAS came in to play. And we started to focus on implementing ERAS protocols. Everything we've always done has been for all our cardiac surgery patients, not just one bundle of patients, but all of them. And ERAS has served as a great foundation to help build our program. A major focus of my role is to support our team's mission to implement and sustain evidence-based practice. And this is across the continuum of care for our patients. We didn't start with a full ERAS program. We've slowly implemented elements, and my position has allowed me to directly be involved in the implementation of these implemented initiatives. I'm also responsible for keeping the team on track and motivated.
The cheerleader.
Cheerleader, for sure.
Yep.
It's interesting. Sometimes I'm asked because maybe one specialty might think that it's their protocol, like a diet, the diet or that area that has been our key to success. But I explain with ERAS, it's the marginal gains from all of our efforts that add up to the sum of our success. And it's everybody, but it's great that everybody feels that ownership. I would also like to tell you a little bit about another position that I hold. I'm a clinical coordinator for the nurse for the Society for Enhanced Recovery After Cardiac Surgery, known as ERAS Cardiac. And our mission is to optimize perioperative care for cardiac surgical patients through collaborative discovery, analysis, expert consensus, and dissemination of best practices. This role has been allowing me the opportunity to help connect healthcare providers with ERAS resources. So we have a website, people submit questions, and I help keep them connected with resources.
So first topic that I want to talk about is, Gina, to you, what does enhanced recovery mean? Just a quick and dirty definition. What does it encompass? Is it just one phase of care? Is it, tell me a little bit about what your thoughts are on that.
Well, that's the hardship of it and the beauty of it, right? It's an all-encompassing, all team members on board, multidisciplinary team that watches this patient from when we began in 2017. We didn't even realize we should be watching and trying to touch these patients in the preoperative phase. And now we're calling that prehab. And then the 30-day mark post-discharge wasn't even enough. And we want to go to the 60, 90s. So I think ERAS is just a continuum of care, adding simple, marginal, just simple components to a protocol that allows us to embed it into the patient's perioperative stay. But it's no one person. It's no one person. So hence there's the hardship. You need to get everybody on board, everybody with the same enthusiasm, cheerleader, pom-poms. This is how we should approach this, that we should be excited for the end result. And that's how we go about it at WakeMed, completely all-inclusive.
Yeah. Well, Cheryl, I loved, you stated so eloquently that it's the sum of all parts, and it's a synergy. So it's more than the sum of that. A lot of people, what I hear a lot is that people say, well, we do a carb drink in pre-op, so we're doing ERAS. So for you, what does the ERAS look like? For
us, we started at a unique place with our protocol and our program. We started with patient engagement. So we worked with a company, created an app so that we would have the patient engagement right from the beginning. And we see that they're a very important part of our success. The more engaged our patient is with the ERAS protocol, the more successful we are. And their reported outcomes are huge. So I'm going to give you an example. We use this app, and patients are able to input information, their reported outcomes, while they're in the hospital. So our patients were writing in the app that there wasn't enough help to ambulate. And this was their words. That spoke loud to our administration. We were able to hire a walking orderly for our intensive care unit. And we made some other revisions with our way that we communicate ambulation on our inpatient floor. So I think some of the key with staffing is showing the administration that the patients are asking for help in certain areas. And I do think that the patient engagement is a huge part of this. So we were fortunate to get the buy-in from our administration to have even this technology, and it's helped us all along to be able to give them their instructions pre-op and give them some self-care help and receive information from them post-op. I hope I answered your question.
That's great. I mean, to have that app and have the information right there and report it back to your administration. Oh my gosh. Yeah. That's huge. Fantastic.
Huge. Well, Vicki, again, you're like a gold standard for all. You're like what all of us are shooting for. And we're going to talk about that in just a second. But tell me, what does ERAS mean to you guys? Is it, a carb drink, multimodal pain, and whatever post-op, or maybe nothing post-op? What does it mean to you guys? Like, what is your bench of success?
In my mind, it's kind of an all or nothing. And it's not, because you can start with just a few elements and grow, what have you. But we decided to just jump, all in, and go with as many elements as we possibly could. And it really, that aside, it's about making the patient a partner in their own care. And to me, if we keep that focus, we're going to be successful, because if you always bring it back to the patient, you can't go wrong. I agree with you, Cheryl. The patients are such a huge part of our success. And if we're not well educating them and bringing them along their journey, then we have failed from the get-go. So that's a really important element for us. But we follow the same process with every single service line. For me, for us, it's just the patient, everybody remains engaged. Whatever we can do to optimize not only the patient themselves, but their journey throughout the entire perioperative phase and beyond. So we want them coming in and leaving better than when they first came to us.
I concur. To me, a successful program is if you have engagement from the patient, from the staff, from all the different providers, and that you're standardizing what you do from a practical sense, that we're all doing it the same way. The variability in all phases of care is what leads to negative outcomes on the other side. And so to me, enhanced recovery is when we all are kind of doing it the same way. I mean, there's going to be nuances to service lines and to some of the different surgeries that we do, but for the most part, we want to make sure that we're marching to the beat of the same drum. And I think that so many people get mired down with the details of like, oh my gosh, we can't do this one piece, so we're not doing ERAS. Well, that's not necessarily the case. You can have a full program, and just because you don't use a specific carb drink doesn't mean that you can't do everything else in the pathway.
Exactly.
Right?
Even after the fact, that if you've started the patient on the pathway, nobody really fails ERAS, right? Like so many times providers, clinicians will ask me, well, what if, we can't do this medication, or what if the patient kind of deviates and they end up in the ICU, what have you? And it's like, well, that's fine. They kind of loop off a little bit, and then they hop right back on, and we get them back on track.
So I'm just going to go around the circle too, and if you can talk about maybe some of the literature that you have used to develop your paths. And I know there's a lot of stuff being published out there. So Vicki, I'm going to start with you.
The guidelines that are out there, the ERAS Society has published guidelines. Those are always a great place to start, but they're not. It shouldn't end there. Right? Like there's so much to read.
You should open the door.
Yes, exactly. The Perioperative Quality Initiative, they have several publications. Poki.org, they have a lot of publications on various consensus statements. The ERAS Cardiac Society has put out, obviously, guidelines. We put out a paper earlier this year on implementation for cardiac ERAS. That's kind of where I start.
Cheryl, you've done a lot of work with these bundles, and I'm sure that there's not a ton of research that say, this is the perfect bundle, but there's all pieces that you've tried to put into, like taking your SSI stuff and all that. Tell us a little bit about some of the research and resources that you've used.
For us, we actually found looking at our outcomes, having a dashboard where we looked at our outcomes and specifically readmissions, root cause analysis, what were the reasons, and then going back and making sure that we applied evidence-based practices to try to rectify those. Our SSI, we have dug deep into the literature, publications from this, we follow things from the Society of Thoracic Surgeons, making sure that we are following what is out there as published best practices. Sometimes you stray on just the smallest things and it can have a large impact. An example for us on that is the guidelines regarding weight-based antibiotic prophylaxis. We were a little below on one area, so we're making changes. And it's all those small changes that have a big impact. And it's interesting with ERAS cardiac in the literature, we're just starting to build it. So we're all latching on to whatever's out there. So we appreciate Gina and Dr. Williams' their publications, because those are circulated with our team to say, look, these are our guiding articles at this point. Our anesthesiologists are always looking for information, and there's some cardiac anesthesia research that's been coming out of Hopkins by Mike Grant that our anesthesiologists have embraced and are mimicking. So, it's kind of all coming together.
I kind of have to say the same off that, Desiree. Yes, we all start, like I kind of do the same thing Vicki and Cheryl said. We all start with the ERAS Society guidelines. We look to those literature reviews. But then I personally utilize each other. I utilize the resources, and once I see outcomes that are outstanding, then we go to that. What did they do in their protocol? What made them different? Which is why I love this group. We have such good resources, and why would I reinvent the wheel when just a phone call or a Zoom away, we could, relate with each other and learn from each other. So that to me is huge, so important.
Yeah, honestly, that is, I think one of the things that has been lacking in our world, I think, anesthesia and, surgeon specific, they kind of have their networks or whatever. But I think as far as like ERAS coordinators, nursing, kind of some of the other multidisciplinary specialties lack that connection. So again, what we're trying to do here. And Vicki, a shout out, because you just had a paper published recently too, haven't you?
I did, yeah. It was April of this year. Myself and the Cardiac Society, ERAS Cardiac Society Executive Board, we published the paper on implementing cardiac surgery, ERAS. So,
Great.
yeah.
Congratulations.
Cool. We'll have to, take a look at that, especially if you're starting cardiac. Now, we know cardiac is super hot, right? A lot of people are getting into that. And that's, you get these cardiac surgeons, they go to a lot of the meetings and they're wanting to bring this back. And that's kind of the cool thing. But there are some still service lines out there that we haven't touched. So Gina and Cheryl, can you just walk us through what service lines specifically are you guys either have or that you're working on? Gina, you go first.
So we started off with cardiac and thoracic, and those have been up and running since 2017. And then in January, when I got the ERAS coordinator position, we are now working on colorectal, hernia, bariatric, breast, cesarean. We started already just this past year, and GYN. So those we're in the works. When I first met you and Monty and started learning about ERAS, I remember very vividly every service line should have ERAS. It should say WakeMed Health and Hospitals and ERAS Hospital. It gives me chills because that was, 3 years ago. And now that is our mission. We have made a commitment to make ERAS a priority at our institution, and every service line might take us 5 or 10 years, but unless I get all those resources I've been asking for, but no limit, all of them.
I love it. Cheryl, what about you? Tell us about your journey. I know you talked about bundles, but specific lines?
Cardiac surgery is our first one, and we're the pioneers for our hospital, and hopefully others will want to join us.
Yeah. Are there any that you're going to try and target first?
At our institution, our colorectal team is doing carb loading. So there is some of that. There are some, our anesthesiologists, of course, because they take care of patients across the institution, or also some of their practices are shared hospital-wide. So I think that we need to show our outcomes. We need to collect our data to foster other service lines from wanting to jump on board.
Yeah, absolutely. Okay, Vicki, can you name all 19 service lines?
I was sitting here thinking about this. Okay.
So I went to you last.
Yeah. Okay. Colorectal, bariatric, urology, gyn-onc, gyn, hepatectomy, Whipple, gastrectomy, mastectomy, DEEP, which is a deep inferior epigastric perforator, autologous breast reconstruction, very different than a mastectomy. C-section, same day, gyn-onc, total joint, same day total joint, Oh God, Jen is on this call. I should have her. I'm trying to think. She's the nurse that works with me. My
right-hand man.
Awesome data person, right-hand person.
Well, I think we get the idea. So you're going ERAS for all,
yeah,
right?
it's like, yeah, pretty much. Yeah. And Gina, you talked about, expanding, and you're like, well, when I can get the resources. And personally, I think that once you start a few service lines and you've hit, like, the biggest thing is, where do these patients go after surgery, and educating those nurses, because once you start, right, it's the same CRNAs that are caring for the patient intra-op. It's the same pre-op people. The surgeons, obviously the providers, we have to work with a little bit, but then the post-op, and that's what it's all about. So as we add service lines, it becomes easier and easier, just because now the majority of everybody is educated. We have to re-educate, of course, every year or frequently, but it's a much easier rollout than it was early on, except for cardiac. That was a challenge.
Yeah.
So that's what you said, Gina. You have a real advantage.
Yeah. And cardiac. I did forget that one. So cardiac.
Yeah.
Okay.
And thoracic. That's
there you go.
one.
So you're almost there. I think you need like 2 more.
Yeah.
So the one thing that I love that you say, and I've heard you say this for years, and it's like in my mind, I have it sticking as I kind of taken a new role myself as a clinical quality person for North Star Anesthesia. So coming again from anesthesia as well, and helping to roll out ERAS protocols and perioperative care models. But the thing that I love that you say about how you start these programs, not how you keep them going necessarily, but how you start these programs, it's like you're militant. Like, you're like, I have my checklist, and this is how we're going to do it.
Well, we literally have a checklist.
I know. That's what I'm saying.
We use the same checklist for every service line, and not even just the implementation, but, we can't bring surgeons on quick enough. So even within, say, colorectal, we have the 7 hospitals, so we're continually bringing on new surgeons. And it's funny because Jennifer or I will be looking at the OR schedules of all the hospitals, and all of a sudden we're like, who's this doctor so-and-so? And they're posting ERAS cases. And I'm like, no. We have not met with them yet. We have not talked about expectations and the pathways. So we call up central scheduling and say, take ERAS off of this case, because it confuses people. And then we probably have a conversation with the surgeon and say, this is what you have to do to come on board.
Yeah, sorry.
So, we have over 120 surgeons participating. And so, there's a process for that as well. But everything is a process. And it's not just about ERAS. I mean, this is straight on change management. Having to create, implement, and sustain, grow a program is all about change management. So if you can get that down, then you'll be successful in whatever service line you add in.
If you're in that zone of expansion, be militant. Get your checklist. Everybody has to do this before you can sign up.
Well, and it's funny because even the surgeons will say like, Vicki's calling me, or oh, God, don't make her mad.
Don't you think, Vicki and Desiree being the experts in this, don't you see that once we made it standardized and we expect that out of everyone, the expectation is high, the bar is hard, that we then saw a ripple effect, the compliance improved, then engagement improved, people were empowered. And so then your outcomes, how can you not have good outcomes?
Right.
So that militant, it sounds tough and rough at first. And I try to very subtly approach those groups as more of a nudge. I love that article, The Nudge Factor. I said that to all my teams, just, hey, I'm not telling you what to do, but here's the nudge. But then really, we are telling you what to do.
One of the topics that I think has changed so much and we really need to talk about in 2020 because it's been such an insane year and life as we know it has completely flipped around. And so sustainability is what I'm getting at here. And it's really hard to keep these programs sustainable. So Gina, let's start with you. Talk to us a little bit about the sustainability factor. What are the things that we need to think about? Because I get this question a lot. Like, I can get this program going, but how do I keep it going? It's a lot of work.
It is a lot of work. It is. But The payoff is so worth it. But you're right. I think that's one of the barriers, the top barriers of implementing and sustaining a program is the ability to sustain it. We have had difficulty with that being a smaller hospital, and we didn't have a robust IT team. We didn't have the reports, metrics, dashboards that a lot of facilities had. What worked so well with cardiac ERAS was that I was able to show them their STS data. I was like, hey, this is how we're doing. Compare it, benchmark it, and say, wow, I think we can do better. But a lot of these service lines, we don't have any other way to look at their outcomes. And so we are struggling with developing that. We are working on that right now. So what can you do yourself while you're trying to wait for those reports and dashboards? Unfortunately, a lot of it's manual, but at the same time, we need to keep that motivation going. We joke about the cheerleader and the pom-poms, but that is a fact. We need to go to every person, and people now joke. They're like, oh, Gina said I was the most important person in the ERAS program, because I tell them that. I'm like, you gave the Gatorade on time. You were the most important person in the program. Yeah. And now they all caught on. I say to everybody. But you have to revisit that. It's not a PowerPoint email, a one talk. You have to revisit that. And then the second piece of that, they deserve to see that data just as much as our cardiac surgeons and anesthesiologists. When they get their reports, we should all be seeing that. Everybody involved in that pathway, the dietitian, the PT, everyone. So we make a very genuine effort to take that back to them. The third piece, as we were talking about this earlier, is like we share these experiences. I take patient experiences, I find those nurses, and it's very cumbersome. I go back, I'd go to their huddles, or I go to the CRNAs, everybody that had a hand in this, and I tell them the patient experience, how we did, what changed because of ERAS. We have to celebrate those wins, and the patient is as equally involved as well. So I get them excited. I cheerlead and talk this up, and then I see them day after surgery, and I'm like, now remember, you are going to dictate. I have to walk, I have to eat, I have to drink, and they become excited. So that is a lot of work. It is, but it's so well worth it.
Yeah, absolutely. Well, Cheryl, I know Gina is interested in this, and Vicki for the app piece of this, but I am sure, has that not helped tremendously?
During this time of COVID, more and more patients are willing to adopt the technology. They like having the connection with us in this way to have information at their fingertip. So a lot more of them are signing up and accessing our platform. And I have to say, we have a robust ERAS oversight committee that we formed, and we meet regularly. We have our outcomes person who has helped us create a dashboard, and every month she presents this dashboard, and we're tweaking the dashboard. I'd say we're still building it. Everybody kind of inputs what they would like for information from our anesthesiologists. Everybody's inputting. So that's one of the ways that we're working on sustaining our program. But yes, the pandemic has definitely inspired people to embrace technology.
Yeah. Vicki, sustainability piece. Tell us about it.
It's so tough. Data is so huge in sustainability, because if you can show the outcome and all the hard work and that you are doing good, that's so important. And yes, the nurses letting them know, the CRNAs letting them know what the data is, what's going on, how they're impacting those patients, but also really getting engagement from administration. Like if you don't have, the approach needs to be top down, bottom up, right? You have to kind of hit it from both sides. And if you don't have hospital administration strongly engaged, people just become complacent. But when you have directors of nursing and directors of surgical services and, chief CRNAs and what have you involved, and hearing all of this and hearing the challenges, then they're going to reinforce. I had an issue once with a CRNA who just every ERAS case she was on just refused to follow the intra-op pathway. And I had talked to her, and I'm a nurse practitioner. And so, Desiree, you can attest that, like, nobody, they don't like me coming into their OR and saying,
that's what you need to do. I'm sorry.
I know. And so I try to do that very carefully, but she just, continued to be non-compliant. So I went to the chief CRNA and I said, look, this is now the third time I'm coming to you. She's out. And she said, absolutely. I won't schedule her on ERAS cases any longer. I'm like, I can't have this non-compliance. And so, it's having those communications and communicating what's going great and what's not going great. When your compliance gets low, you gotta figure something out. It's all about the compliance, the engagement. I think it was last year. We have ERAS committee meetings at every one of our hospitals. So every month, some of them are every other month now. But it's the same date and time all the time, every month. And so, I started seeing that less and less people were engaged in the meeting. They wouldn't show up. They wouldn't call in, what have you. And so finally I went to my counterpart, hospital administration, and I'm like, okay, we've got to blow it up. We need to look at the guest list here. And, if they're not going to show up to the party, then why are we continuing to invite them? Because the goal in having these key people at the table is, I'm only one person. I can't go around and relay messages and make sure things are getting done. It's their job to bring it back to their departments and their people and making sure it's getting done. So if you don't have that level of engagement, it's going to be really hard to sustain a program. So that and your data, super key.
Yeah. So the takeaway for me, Vicki, two things. One is the data, and I think all of you guys said this. And I think this is why a lot of programs fall flat, is that they share that cool stuff. Like, we have reduced length of stay by half. We have cut out whatever it is. They only share it with their core little group.
Yeah.
And everybody needs to hear that. Like, that is a win for everyone. And the patients need to hear it too. Like, they need to, because gosh, what better references than patients, to this. Mm-hmm. I know surgeons also drive sustainability as well sometimes, because if, I know in the current situation where I'm at now, a couple of the surgeons are like, look, they're not doing a great job about getting my patients up. Do we need to get PT in here, or, what's going on? So they see some of it. But to your point, again, with the data, Vicki, I remember you telling me a little anecdote of where you were looking through it and you saw, I think it was like your MMEs or your morphine equivalents had raised 1 month. And then you went back and you did a little bit of a chart review, and you're like, you kind of were able to pinpoint a person or a couple people or a service line or something like that. So that's really a great example of using your data.
Looking at not just patient outcome data, but the process, the compliance data, because if your outcomes, all of a sudden are not as great, is it a pathway issue or is it a compliance issue? And oftentimes you see that, okay, the outcomes haven't been so awesome and your compliance has gone down. We need to fix this. But one comment about data that's so important is that who's collecting that data? You can't have people collecting that data if they don't understand the data, because you have to be very intentional about the information you're pulling from the medical record. When I first started, the APCs, advanced practice of PAs and other NPs, were collecting. They were not involved in the program at all, but they were asked to collect this data. And so I went in and looked at the data. I'm like, this makes no sense to me. And I said, no, I'm going to take over the data and now Jennifer has taken over the data. She's on this call. Thanks, Jennifer. But it's really important that the person collecting it understands it and knows what they're collecting. Otherwise, it's not going to make sense, and it's not going to be accurate.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.